Well, now we're moving into our first panel of the conference. We have a very distinguished group of experts to discuss issues related to how we're going to assess health outcomes following mass vaccination in our country and globally. The panel will focus on challenges including ensuring equity, second dose adherence, monitoring side effects, measuring the duration of the immune response, and determining medical contraindications to vaccine use. We will also discuss opportunities to modernize the public health response with digital technology solutions and how citizen-centric tools are critical to this approach. Well, it is a great pleasure that I introduce our experts to you. A global vaccine expert and policy leader who brings decades of experience to our discussion, Dr. Bruce Gellin currently serves as President of Global Immunization at the Sabin Vaccine Institute. Dr. Gellin previously served as the Deputy Assistant Secretary for Health and Director of the National Vaccine Program Office at the U.S. Department of Health and Human Services. We are so honored again to welcome Dr. Victor Zhao, who I mentioned is the Distinguished President of the National Academy of Medicine and Vice Chair of the National Research Council, who provided plenary remarks earlier at this conference. Dr. Zhao previously served as Chancellor of Duke University and President and CEO of the Duke University Health System. He is an internationally acclaimed leader and scientist whose pioneering work has significantly improved healthcare in the United States and globally. I am also very pleased to introduce my colleague, Dr. Josh Sarfstein, who is the Vice Dean for Practice at Johns Hopkins. He is a professor there. He previously served as Principal Deputy Commissioner of the FDA, and he also served as the Director of the Maryland Public Health Department and the Baltimore Health Department. And he brings an extraordinary amount of pioneering public health leadership to our discussion. And our last panelist will be Dr. Nundi. He is a practicing primary care physician in safety net hospitals. He's an entrepreneur, a technology wizard. He served as the digital health leader at the World Bank Group, and currently he serves as the Chief Digital Officer for Accolade, a group that is bringing digital services to 2 million working Americans. So I want to begin with a first question. Dr. Gellin, you served in the government during the anthrax attacks and H1N1 pandemic. What lessons have we learned and what technological innovations could be helpful in measuring health outcomes following mass immunization for the COVID-19 pandemic? And what are the differences in the types of vaccines? How should a person choose between them?
So I think I'm going to stick with the first part of that, given timing. We can get into the other parts later. But I think that, Susan, you raise a good point, that what we've learned before about pandemic preparedness needs to apply now, but it's a different era. I think the focus here is on the health outcomes part. We've heard from great speakers before us about the complex logistics, global equity, and actually national equity at every level, because every country is going to have to make those decisions. Some of the privacy and some of the policy issues, but wanted to focus on the health part. And I think that's where it's important to remember that vaccines are unique, that they provide protection to an individual and provide a protection to a community. So when we think about health outcomes, we should think about both of those. What can we learn about the individual health outcomes and the community as well? We've also seen, and we heard many times about the FDA Advisory Committee last night. It was just in time for the national news. Every network had B-roll footage of trains, planes, automobiles, vials, dry ice, monitoring. You got it. All about logistics. But at the end of the road, the logistics is about what Anurada was talking about, that last mile, because it has to turn into a vaccination. So from a health perspective, you've highlighted some of the things we have to continue to learn, things that we didn't learn in the clinical trials. And so I guess I'll start with thinking about how do we think more about digital clinical trials? We'll put that out there as a topic broadly, but I think how we can certainly learn a lot from what's happened now on how we can modernize clinical trials and make them more efficient. We do have many more questions to learn, for which there's going to be a lot of need, for which there are digital solutions. determining the duration of protection. We don't know that yet. We're going to need to. A critical question is understanding whether this vaccine blocks transmission. So it's another set of studies for which we can overlay a set of digital tools to come up with some of those solutions. And probably most important question that's been looming for a long time is about safety and the degree to which we have ongoing safety monitoring systems in addition to those that we saw in the clinical trials, to make sure that the vaccine continues to perform in real world settings as we expect it to based on the clinical trials. And that probably is maybe the most important place, because that's what people are concerned about the most, the degree to which we can have some of the solutions for that to get real-time answers, particularly in trying to discover if there are rare but serious adverse events that we haven't seen before. And those are the same things we need to learn about. And then finally, we need a better system to understand vaccination coverage. Right now, it's for routine things, it's done by phone calls, the National Immunization Survey. Clearly, that needs to be modernized, for which this audience has great solutions. And that will also give us perhaps a real-time answer to this, mythical herd immunity, which is, we all know it's real and it's there when you see it, but how can we determine when we're there? So I think that's another piece that we'll be able to learn. And I encourage this audience to think about how your various tools will help us answer some of those many questions. Thanks.
Well, thank you, Bruce, for setting the stage for us and really challenging our audience to think through some of the important digital solutions that they could bring to these processes. Dr. Sharfstein, as a leader at the FDA in previous administrations, can you walk us through the FDA's processes for authorizing these various vaccines? How does the FDA think about the standards to use? And as we witnessed yesterday, the United States is the only country that opens up the approval procedures for public comments. How does this transparency help or impede the process?
Sure, and
welcome.
Thank you, and thanks for having me, Dr. Blumenthal. It's great to be with such a distinguished group of panelists here. This is an unprecedented situation because the pandemic is unprecedented, so there's never been anything quite like this. There's no cookbook the FDA just pulls out. The FDA had to write it this time. And as Lawrence Costin said, the FDA did a very good job in the face of some political pressure otherwise to articulate and make public standards for both safety and effectiveness to guide clinical trials to the point where you could have such a robust set of data to be presented yesterday. And then based on that, the FDA is going to look at the data on efficacy, which was very strong, the data on safety, and is, as it announced, planning to authorize the vaccine. I think that there will also be a lot of instructions in that authorization that will get a little bit more granular about, for example, how to think about the vaccine for specific populations, who shouldn't be vaccinated right at the beginning, and other things like that. So I think the agency is set up to not only make good decisions for where we are right now, but also explain them well, which gets to your question about transparency. I think I'm particularly happy to see the FDA have this advisory committee. Now, some people may look at it and go, well, people had all kinds of ideas. Some people who spoke were mistaken. That may be true, but it's also true that it gives a chance for the world and a lot of people in the United States, a lot of medical professionals, a lot of people who legitimately have questions to really see the data and hear how some of the best experts in the world think about the data and can bring different pieces of the puzzle together to explain their judgment and insight. And people at FDA particularly have tremendous judgment and insight. And I think that in the end, that will make the understanding of the vaccine within the medical community and beyond much stronger. So I still think there's a lot for FDA to do in terms of explaining itself, being rapid in responding to questions as they come up. Dr. Gellin did such a good job explaining the critical tasks ahead. We don't know everything about the vaccine, and we're going to learn. And it's really important for the agency to continue to be forthright, bring in external advisors when necessary. That's really going to build the confidence, I think, that will make this vaccine program a success.
Well, thank you, Dr. Sharfstein. I think coming from you, this notion that the FDA really will build public trust and healthcare provider trust. I think that's such an important word here across all the various populations, whether it's physicians, administering, whether it's the public, getting vaccinated. And this will be a challenge, which brings me to Dr. Zhao. You've talked about key issues related to equity. We need to, as has been discussed earlier in the conference, how are we going to distribute these vaccines? And importantly, then, how are we going to measure outcomes, medical outcomes in our country, in diverse states, rural communities, underserved communities, and also around the world, in the developing world. Are there innovations that help us track these developments across the United States and world? And if not, the National Academy of Sciences is very well positioned to think through an innovation agenda. Your thoughts on this?
Yes, I said earlier that the last mile is actually a very difficult mile. If you think to begin with, we probably end up being able to have about 20 million Americans vaccinated by the end of the year, maybe 50 million by January. So there's going to be limited doses. And the first issue is who's going to get it first, second, and third. And as you know, the CDC and National Academy have come up with a framework that really looks at vulnerability and trying to protect the people most vulnerable. So I think we all agree they're frontline workers, elderly in nursing homes. But when you begin to get into the broader population, such as high-risk communities of color, people with comorbidities, it's not clear to date because these allocation are guidelines, and it's up to the state how to implement them. And as the vaccine get down to the state, to the jurisdictions, it will have to be therefore determined how to actually implement the allocation framework. And I think the decision of whether you look at counties and population with high risk or looking at individual information is still not clear. So there's a lot of work to be done. I think the easier one would be nursing home and others. So you do need, in fact, good also tracking ability to look at, the information, who's vaccinated, and what's the long-term outcome. I think the other issue is safety. The approved vaccines have only 2 months of safety data, and of each population, about 20,000 vaccinated. And as you know, you won't see the rare Guillain-Barré and other side effect until millions are being vaccinated. So the tracking of safety is really important. Now, CDC does have vSafe, and they use a surveillance system. And now they're introducing into smartphones for those individuals who can report their own symptoms, etc. But still, there's a need for the ability to validate the data, to collect it, centralize it. You heard about the issue of identifiable data and the issue of privacy. But at the same time, we need that data to be able to know at each state and nationally whether we're making progress. What's the outcome? What's the safety? So I believe there's a lot of work to be done. Thank you.
Thank you. Dr. Gellin, there are multiple vaccine platforms that will be available to the consumer. How will individuals, states decide which platform, which type of vaccine to use? What will be the benefits of each? How will we track this? How does digital technology help us? I saw this morning that Australia was withdrawing its vaccine candidate that it was developing there in that country because some of the participants tested HIV positive falsely. How can these be, these decisions be made? And how can technology, help assess these health outcomes?
Well, it's a series of complex questions. I'll start though with the supply. What we're focusing on now is the initial vaccine that's going to soon be available to start the vaccination program. There are others in the pipeline, as Josh talked about the approval process. The Vaccine Advisory Committee is going to meet every time in public, so I have a chance to look at that, and I'm sure they'll be having those same kind of conversations to try to think of, are there differences between the vaccines which make them better for some populations than others? In the near term, I think it's going to be mostly about supply. And until that changes, people won't have a lot of choice because the distribution will be of the vaccine that's available. That may change later on. And again, as we learn more about the differences of the different vaccines and how they may perform, they may be better for some than others.
Great. And I saw that the UK was thinking about mixing up the vaccines. Can you talk about that? Giving doses of one and doses of the other. What would be
that would be the worst thing to take out of context? That would sound horrible.
Okay.
There'll be a lot of mixing up that goes on, but it's probably not that. What they're talking about is what we've thought about this before, is when there are different vaccines in the system that are available, and we know that they require 2 doses. We don't currently know whether getting a dose from Pfizer followed by a dose from Moderna gives you the appropriate immune response. We can guess, but we shouldn't be guessing. We should know. But because there is the potential that based on supplies, you might get one vaccine initially, and then what's available is different, it'll be critically important to know how they perform when you have these so-called mix and matches. So I think that is really an intentional science project, if you will, to make sure that as we have more vaccines available, we know what their performance characteristics are when used in various combinations, which is likely to happen in the real world.
Well, thank you very much for your thoughtfulness on that. Dr. Nundy, there's been some concerns about top-down approaches to collecting data, vaccination data, and adverse event data from patients, as Dr. Gostin mentioned earlier in his remarks. As a health entrepreneur, do you have ideas about how to build citizen-centric systems that are focused on the needs of the end user and that would protect privacy?
Yeah, that's such an important question. I think the first part of it, tying to Dr. Zhao's comments about outcomes, there's a common saying right now that a lot of people are saying that vaccines don't save lives, vaccinations save lives. So when we talk about measuring outcomes, a lot of the outcomes we're talking about are the vaccine outcomes, right? Side effects and effectiveness, and those are super important. Equally important is outcomes around vaccination, right? What I'm talking about is the experience of getting the vaccine. Do people feel like they were properly explained what to expect? Did their side effects that they got match their expectations? Even things that are somewhat controversial in public health, like a net promoter score. How powerful would it be to be able to measure 7 days or 14 days out? Would people recommend the vaccine to friends and family, right? Because a lot of us get our knowledge and expertise from public health officials. But when you talk about the patients that I serve in inner city DC, a lot of where they get their information from is their neighbor. And so are we tracking that? Are we trying to understand whether it's being delivered at a clinic, at a CVS, or somewhere else? Are we trying to understand how that's being delivered, and how are we serving patients and making sure that they're understanding for themselves what the value of this is? To your specific question, yeah, the idea of end user design, I think, is essential, right? Like, what are the words that we're using? What is the information that we're providing people? And when it comes to things like privacy, I mean, that the transparency, that's critical. The other piece is value, right? If someone's looking at a system and saying, hey, if I call this number, if I send information in, it's going to get sucked up into the cloud somewhere, and it's going to go to the government. What's the value that I get, right? If I'm having a side effect 3 days out and I'm saying I'm having a rash, and I just enter it into it, and the system says, well, thanks so much, and you don't hear from anybody, that's not really creating end user value. So I think what we've learned is that delivering value back. If someone's saying they have a symptom, are they getting a call from a nurse or somebody that's saying, hey, can you tell me about that symptom? So to them, what the end user is seeing is, hey, this is a tool to help me manage my symptoms. Now, on the backside of it, we could be using the data to also understand longitudinal outcomes, and we should. But if that's the only reason that we're doing this, I think you're not going to get the engagement that we ideally need and want to see. And so those are some of the things that we've learned as we've scaled some of these systems in other contexts.
Thank you. And, as in terms of your work at the World Bank, what have you seen in terms of the uptake of digital innovations, mobile phone use, in the developing world?
Yeah, no, I mean, it's been incredible. I mean, I think, in the developing world, like looking at Africa, where I spend a lot of my time, it's the youngest continent on Earth. And for a lot of us, like for me, it's a luxury to use my phone because I also have a computer here. I have another computer here, I have my clinic laptop next to me. But in many contexts, phones are how it becomes a necessity for the poorest, right? It's how they bank. It's how they get work. And so we've seen it as a really transformative technology. I think some of the examples that have been really compelling. So if you look at, around this last mile issue, like organizations like Dimagi. So they've created a simple mobile phone-based app that empowers community health workers and now end users to be able to do things like diagnose and treat malaria, to follow up on women post-pregnancy, and yes, to do vaccination. And I think part of those lessons we should be reverse engineering back to the U.S. Part of what's going to be needed, I think, in the most vulnerable populations is to go door to door, telling people about the vaccine, helping them understand what the value is. They may get vaccinated at a depot where we can get scale, but I think really that sort of buy-in process might have to be a lot more local. And so how do we give a tool to community health workers or others so that they know which households to go to versus others, so we can have a really efficient process? You think about what we did to get the vote out. We should be bringing some of those tools and ideas to help get the vaccine out. I mean, ultimately, 12 months from now, when we look back and the dust is settled and we're trying to understand the success, it's all going to be about, did we get this to the right people fast enough? And I think that's all about really the way we think about equitable distribution from day one.
Susan, may I ask Shantanu a question?
Sure, of course.
Yeah, so
Shantanu, good to see you, Dr. Zhao.
Good to see you too. Good to see all my friends on the panel. So here's my worry. If you heard my talk about Accelerator, it's the players coming together to form a coordinated strategy and approach. And of course, the technology you talked about is great, lots of innovation. But I worry there's not, in fact, even within the state, a coordinated approach of saying, what will you use? Who should we use it? How do we collect the data together? So I think one of the issues has to be that some entity needs to look at the great things you guys are doing and then decide, at least for now, adopt it, use it across in a standardized way to move forward. And I worry that so much in our country, the digital world is totally decentralized. I heard earlier, of course, Ramy say it's good to be decentralized, and I kind of agree with that, but it's not good when you don't have coordination and going different directions. So can you say a word about that?
Yeah, no, well, you're absolutely correct. There's a tension between top-down centralization and decentralization, right? I think the power of decentralization is that empowerment, that local tailoring. People, will know their community well, will already have the trust established. We've heard about trust. Medicine moves at the speed of trust, but there is that need to make sure that it is coordinated and that the information is being collected. And it isn't an easy problem. Part of it comes to partnerships. Part of it comes from the role of government. I think things like developing those data standards, the APIs, the software development kits, what they can do is they can allow us to have a standard that we're using, but the end application and who the end application is used by can be much more flexible, but you're still collecting a common set of data. But I agree, it's a challenge. But I also think, especially given that speed is so critical here, we have to really understand what success is going to look like, right? Is success going to look like 12 months from now, knowing that the adverse event rate was 1% versus 1.2%? Or is success going to look like, again, 12 months from now, that we reached the people that needed to get this as soon as we possibly could and save lives? And I think in the need to prioritize, especially in the lowest income communities, on balance, I would choose more decentralization to get the vaccine out than necessarily better data collection.
Well, I think, your points are very important, Dr. Zhao. I think, the need and what's been missing in this response in many ways has been a national plan for innovation that brings all the players together to develop, a strategy. But from your perspective as well, Dr. Nundy, I think the importance of citizen-centric involvement, I thought your voting analogy was very important, that yes, there's a national strategy to get voters out. They're using various tools to do that. But ultimately, it's what's going to micro-target different groups of voters to get them to express and use their own powerful voices to make a difference. And so I think there needs to be some balance between that. And I wonder, Dr. Sharfstein, you've been a very important public health leader How do you see technology working at the community level?
Well, it's an interesting question. I really find this conversation fascinating. You know, the question that Dr. Nundy said, which is, well, we really need to look back and ask, did we reach the most vulnerable people? That's not a question that can be answered entirely in a decentralized way, right? I mean, just starting, you need data standards, but someone's got to actually look at that. Someone's got to look at the denominator of vulnerable people. Someone's got to say, well, were they reached? Were they offered? Did they get it offered near them? So this is not, I think, solvable by government alone, but it's not solvable just through, 1,000 points of light. There has to be a balance there. And I think it really requires a strong public health infrastructure to be able to work with innovators and be able to incorporate innovations in accomplishing the critical tasks of vaccination. So, I think that would, I think CDC is sort of inching its way into that with this, but there's so much more potential that could be realized. To your question, I think one of the more interesting things to me will be as we see for sure a lot of variation around the United States and I'm sure around the world, how well are we going to be able to correlate the vaccination and the different types of vaccination success we're having with the outcomes that communities are seeing? Because the number to keep an eye on is community transmission of COVID. That's the number. That's the number that allows us to go back to our lives. If people are vaccinated, that's great. If community transmission goes down for whatever reason, then it's going to be easier for kids to go to school. It's easier for businesses to open up. It's easier for everything. So how does the vaccination approach really allow for that to happen? How does that combine with other public health strategies to allow for that to happen? We have to keep our eye on the outcome that really matters to all of us, which is fewer people in our community getting sick and dying of COVID.
Yes. Well, I think this is, a really important discussion that we're having because, as I mentioned earlier, public health, as we're rethinking and redesigning and reimagining public health infrastructure for the 21st century, public health and technology really need to come together in new ways. And I think it begins, again, with these kinds of discussions about how we bring the perspectives together at the citizen-centric level, along with the community and national levels, because I think everyone in this discussion has a very valid point about the perspectives that need to be researched and collected and analyzed in order to make sure that this massive vaccine deployment is successful. Dr. Gellin, some experts have been concerned about the potential for vaccine-enhanced disease for COVID-19 that has been previously observed, for example, with dengue, Zika, and Ebola viruses, and may have a similar mechanism in COVID-19 where the presence of a non-neutralizing antibody response could be driving more severe disease outcomes. What should be done to assess both waning immunity and enhanced disease over the next 2 years of the study period as the vaccines are rolled out?
Well, it's interesting because those are two ends of the spectrum where they meet together, the waning immunity and the enhanced disease. But essentially it boils down to what we were talking about before, is how these vaccines perform in the real world. And that's why particularly the ongoing assessment of safety, we've heard about some of the safety monitoring systems, how those have to be tuned up better than ever to be able to look for those, because what the biology there is that those who have been exposed before have some baseline immunity, and when re-exposed could have a accentuated immune response that is skewed. We need to look for those. That was discussed yesterday. That's been looked for in the clinical trials, but you'll only see that when you then subsequently encounter that, and we'll need to be keeping an eye on that one. It's a concern. Right now, it's a theoretical concern.
Okay, excellent. Dr. Zhao, as an innovation pioneer, what are your hopes for the future when it comes to digital and data innovations for measuring vaccine health outcomes in the US and globally?
Yeah, I think it's already been discussed by a number of the panelists that what we really want to be is have user-friendly, consumer-friendly center point of view that protects the privacy issue, but being able to collect that information in real time. But I also feel that that information should in fact be coordinated and be able to be used to measure true outcomes. And this is where the issue about local, state, and federal becomes a really important issue to be aligned. I think technology, which is really impressive from the panelists, from the people in this meeting, need to be somehow or other feed into a national strategy, a plan, as you said, at least a state strategy followed by national strategy.
Excellent. All right. Well, thank you. That's very helpful. Dr. Nundi, can you talk a little bit about some of the technologies that have, really worked in the developing world, the rise of mobile technology? How is that coordinated in terms of the inputs, tracking vaccines, for example, participatory epidemiology? How is that unfolded in the developing world for other vaccine initiatives?
Sure. I think, the most useful way to answer that might be to pick some specific examples, and around specific use cases. So I think the first is around this idea of really powering personalized mass communication. That's a big area. And we've had success here in the US, not along vaccines, but if you look at Text for Baby as an example, of a really simple tool to text in, start to get personalized messages timed to your gestation period through the pregnancy and beyond for the newborn period. In South Africa, they've taken that model and really put it on steroids with the system called Mom Connect, which is actually a two-way system. And what they find is, because, care starts at home, the ability to be able to connect in to families and to caregivers in the home, even before, they even think about going to the health system, has been really impactful. And I think something like that you can imagine being used pretty easily for people to understand for the vaccine, the benefit. The second is the idea of distributed models, right? Particularly in lower resource settings, we need to push care out of clinics and hospitals that are few and far between, but also not trusted, into churches, into communities, into homes. And so digital has a huge role to play for that, because the challenge, as Dr. Zhao alluded to, is once you go out of the clinic or hospital setting, you also lose access to distribution systems, information technology systems. And so mobile phone-based systems have enabled a much more distributed approach, yet that can remain coordinated. So I mentioned earlier the example of Dimagi. There's many examples of mobile phone-based software systems that are used for point of care documentation, and for supply chain management. And then finally, this idea of the collecting longitudinal data, that's been shown as well. And again, I think a key lesson there is if you can pair data collection with service delivery, right? So, even here in the US, researchers at Duke, as an example, in the early part of the pandemic, launched a very simple mobile phone service where they were collecting information on symptoms of COVID longitudinally. But again, if people had symptoms, you get a call from a care navigator. And so what they found is that solution is scaling very quickly, particularly in the lower resource communities. And so those types of solutions we've seen be able to take some scale here in the US and elsewhere.
Thank you very much. Dr. Gellin, are there some other thoughts that you would like to add to this discussion in terms of measuring medical outcomes in our country and globally?
Well, I think we've laid out the things that we need to be looking for that are going to add to the evidence, so we know how best to use the vaccines in the populations. But I'd like to circle back on one of many of Dr. Nundi's comments about the experience, this early experience. I think that what happens next, I think, is going to be critical to what the trajectory is of the vaccination program. The people on the front lines are going to have to answer questions for themselves, but because many of them are healthcare workers, they're going to be looked to, as they are all the time, for their advice by their patients, by their families, and by their neighbors. And I think that experience, not just the did they get it or not, but the things that Dr. Nundi talked about, what was that experience like, is going to have a huge impact on what people do. Many people are appropriately taking a wait and see attitude. This is what they're going to see, and how to amplify that, I think, is going to predict how well this goes.
I think you're so right on this, and I think that given that the healthcare workers are often the people that patients will look to for their experience in terms of adopting a public health recommendation, that these frontline workers will be doing a lot in terms of engendering a trust in the populations that they serve. Dr. Sharpstein, there has been modernization of the FDA over the past years. How are they doing? And what are your thoughts about, improvements and also the integration of digital technology moving forward? I know that a new center has been developed for apps for medical purposes. Where do you see that going as mobile technology becomes more a mainstay of public health and medical practice?
Sure, that's a very big question. There's a lot that the FDA is responsible for, and there's always a need to check to see how the FDA is doing with respect to the tremendous innovation that happens. The FDA's one of its main missions is to bring that innovation to patients in a way that really matters for them, and distinguish between the wheat and the chaff. There's people every day saying that they've solved every problem, and you've got to figure out where the technologies that have promise are really help. FDA can really help bring those forward if it does its job well. On the particular question of apps, I think it's a balance, because you absolutely want to have tremendous innovation. On the other hand, you want people to be able to tell the difference between apps that are correct and apps that are incorrect, between things that matter and things that don't matter. And so, I think that's always the struggle with FDA, to find that spot and constantly be willing to adjust it based on what you learn. So, I think it, like many things FDA, it's an ongoing story, but and depending on where any one person is, I've met people who are doing innovation who say it was FDA that made this innovation possible. FDA saw the value, gave it this particular kind of stamp of approval, and that's made this work, and so many people have benefited. And then, of course, you also hear from people who say, I'm having trouble getting FDA's attention. I think this might have a big deal, or they told me they didn't like it. And so, that's kind of the nature of FDA. But I do think responsive and accountable ways of thinking about apps is just extremely important, will only be more important in the future.
Thank you. Thank you very much. Well, the last question I want to ask all of you on this panel today is, how does the COVID-19 pandemic end? And do you have any predictions about when that might happen? Dr. Gellin, would you start?
It depends how you define end. I mean, we know from history that in 1918 was a good example. When influenza showed up on the scene, it occurred in a few waves, and it became a seasonal issue. I think what many people have talked about is how we're going to have to learn to live with this virus. We may be surprised, and it could magically disappear, but it seems that's not the case, and we're going to have to learn with it. Now that we have better tools, that's going to help quite a bit. Until we get those better tools and know how they perform, we're going to have to stay where we are right now. And I do worry that the people think the problem is solved just because the FDA advisory committee gave it a good vote. That's not the case right now. But I do think that we're going to have to see over time how the vaccines and the various tools perform. But to me, it's unless there's something that we haven't experienced before, it's going to be based on immunity in individuals and the populations. If the virus can't find a place to go, that's how we're going to beat it.
Thanks so much. Dr. Sharpstein.
Well, I think it's about community transmission. When we can get community transmission down and recover, the critical things that we need to do, that's when we'll wake up and realize that we've moved past the pandemic. And the vaccine plus other public health measures are going to be necessary to make that happen as quickly as possible.
I think that's such an important point that, we have a life-saving tool, vaccines. They were the landmark public health accomplishment of the last century, but we need to make sure that we combine this with proven public health practices, other proven public health practices like masking, proper hygiene, and social distancing until there is widespread community uptake. Dr. Nundy, your thoughts?
I mean, I agree with Josh technically, and I think that's the right answer. I think what I'd add is that things are never going to go back to the way it was before, and it shouldn't. People going to the office or into schools when they have a cold. If you look at what's happening with influenza right now and how we've broken transmission, I think the real question is going to be, how can we actually prevent us from sliding back on so many different fronts that we've been able to push forward because of this tragedy, and really how much further we can push things forward, from me seeing my patients virtually, or at least giving them an option to being cared for virtually, to the acceleration of digital health. I think the vaccine is a tremendous opportunity for us to increase belief in science, to inspire an entire new generation of scientists to grow up and to want to become scientists and use their degrees to serve mankind. So I kind of take more of the optimistic view of how we can really take this moment. Healthcare wasn't perfect before we got here, and it's not going to be perfect after. How can we get closer to where it needs to be is really the question I think all of us need to help answer.
Well, thank you for those comments. I mean, if you think about it, 40 new diseases have emerged since 1968. AIDS, hantavirus, West Nile encephalitis, Lyme's disease, Zika, and now this novel coronavirus. So, we really need to use this opportunity for pandemic preparedness and response, to marry public health and technology, to accelerate the advances that can happen, and make sure that they are well funded for the future, because this generation has had this coronavirus, but as long as animals and humans are living in close proximity, there are new infectious diseases that we need to prepare for. Dr. Zhao, the last word here. You run the Distinguished National Academy of Sciences. You've convened an important seminar conference and issued a report on equitable distribution of vaccines. Can you share some of the key recommendations and what the Academy might do for the future in terms of the innovation agenda that our panelists have spoken about?
Yeah. So with regards to the pandemic, it will end. But the question is then, what does it become? I don't think it's going to go away. As my fellow panelists said, it could become endemic. We have HIV, we have some of the infections that we learn to live with, but in fact, we get immunization, good public health to keep it at bay. It could be seasonal and pandemic. So I think it depends. But I think, as you said, Susan, the importance of bringing science and then also bringing public health measures and continue to learn from COVID. We, in fact, are doing a major study, international, but funded by HHS, to look at how would COVID teach us about seasonal and pandemic flu. How would it change the way you make the vaccines, Bruce? And of course, I'm sure Bruce is thinking a lot about this. How would you change public health measures? So I think that's where we're going to end up, in my opinion. Your question about allocation, well, as I said, I think equity is the key. When you look at the vulnerable population, those who are likely to get severe disease, those who are likely to die from it, that's the first population we need to protect. And so in thinking about equitable framework is what we talked about. And so clearly what we're using, aside from the frontline workers, is a social vulnerable index. So rather than using skin color, as we know that in fact, the communities of color have greater risk, but they have greater risk because they're more vulnerable from a socioeconomic point of view. So we use a social vulnerable index to decide what communities do we need to bring the vaccine first, etc. I think that's the way to go. In other words, it has to be fair, transparent, equitable. It has to try to protect everybody. And my last point is, this whole pandemic teaches us a lot about human dimensions. We need leadership that makes decisions based on science. And we need every citizen to protect themselves and each other. This is for the common good. And I think that needs to be heavily emphasized. Thank you.
Thank you, Dr. Zhao. And I think thank you for underscoring that from challenges come opportunities for progress. I want to thank Dr. Zhao, Gellin, Sharfstein, and Nundi for sharing their extraordinary expertise with us today on battling the COVID-19 pandemic, the most dangerous threat to our health, the economy, and national security of the 21st century. Let me conclude by reminding our audience that throughout history, infectious diseases have killed more people than wars, and we must remain vigilant against them. To successfully win the battle against this disease, our country urgently needs a national plan guided by science, a 21st century response and prevention paradigm that combines the most cutting-edge technologies in science for surveillance, testing, treatment, and vaccine production and deployment, combined with proven public health practices, mobilizing all sectors of our society. And that means that each one of us must intensify our efforts, working together to fight the war against this coronavirus so that someday soon, COVID-19 is a disease found only in the history books. Thank you.